Okay, shall we make a start, Virginie? Okay, so hi, good afternoon, everyone. Thanks for joining. Today, we have the pleasure to have Dr. Nadya Yousef, who is our guest speaker today. A very elegant name in the world of neonatal ultrasound. She's a pioneer. We have Virginie, and I'm hoping that Almudina will also join us to be our panelist today. Thanks for doing that. I will just hand over to Virginie. Just for housekeeping, please, if I can ask the attendees, if you keep your mics and cameras off, happy to put questions in the chat box, and also after the presentation, we'll be happy to take questions as well. So over to you, Virginie.
Thank you very much, Mahmoud. I'm extremely grateful and honored today to moderate the session with Nadya. She's a wonderful friend, and I'm very honored to moderate this session with another wonderful person who is also a key researcher in the area of lung ultrasound from Spain, Almudena Alonso. So Dr. Nadya Yousef is a consultant neonatologist and deputy head of the NICU at Paris-Saclay University Hospitals in Paris, France. Dr. Yousef graduated from the University of Oslo in 1995 and her MSc from the University of South Paris in 2008. She has trained in Norway and in France. She has a broad experience in neonatology and neonatal intensive care. Special interest areas include point-of-care ultrasound and the use of simulation-based training to improve patient safety and quality of care. Dr. Yousef is a pioneer in the field of neonatal lung ultrasound and has published extensively on the subject. She directs a course on neonatal and pediatric lung ultrasound in Paris. She also co-directs a course on neonatal lung and cardiac focus with Jorgen Singh. And she has taught and lectured internationally in Europe, Africa, Asia, and North America. She's a founding member of the French group of pediatric lung ultrasound, the JEP, and a member of the Ethnic POCUS Working Group and the Ethnic POCUS Certification Board. She's a co-author of the International Ethnic POCUS Guidelines. All to you, Nadya. Thanks so much for talking to us about the use of lung ultrasound as a tool for surfactant therapy.
Well, thank you very much, Virginie, and thank you, Mahmoud, for inviting me. It is an honor for me. I'm very, very pleased to be. This is my first time with NeoFOCUS-UK, so I'm extremely happy. Thank you for this introduction, Virginie, and thank you all for joining. So I know that many of you are already using lung ultrasound. Possibly some of you are just starting, but I know many of you are quite experienced. So I'm not very sure about housekeeping, but I would be happy to have any questions on the ways, or if Mahmoud, you think it's better, take them in the end. So today we're here to discuss a little bit about how we could use lung ultrasound to help us in our surfactant treatment policies. So I have no relevant conflicts of interest to declare. Lung ultrasound, like any other forms of point-of-care ultrasound, is an extremely useful tool for us clinicians, in my opinion, because it's goal-oriented. We perform it at the bedside and we can repeat it as many times as we want. It is an adjunct to the clinical examination and to the monitoring tools, and as such must always be interpreted in the clinical context. And this is especially true for the newborn and, for example, respiratory distress syndrome, because, I mean, the findings we'll see on the screen will be specific to that patient population, and we'll go through that further. We're working with newborn babies. They're small, easy to scan. They have lovely lungs, I must say, when we scan them before they start to get any chronic comorbidities. And of course, we do have specific challenges. We're dealing with specific diseases in that age group. We don't really have a satisfactory gold standard. Most of us might be using chest x-rays as well. And we do know that as any technique, there are a number of limitations. And we have increasing concerns about potential long-term effects of all this radiation in this age group. So the international evidence-based recommendations are a first step towards what I hope will be more collaboration and working together towards really having specific guidelines that might help us all work in a homogeneous way. There is a chapter on lung ultrasound in these recommendations. Some of them are more general, but as you can see, one of these points, point number 12, is that the focus is helpful to distinguish between RDS and TTN. And the indications for neonatal lung ultrasound as recommended is for the diagnosis of pneumothorax, fusion, and then specifically neonatal diseases such as RDS, TTN, and meconium aspiration. And as for any other patient group, we can use it to recognize lung edema, whatever the cause, and evaluate lung aeration and use it for recruitment, which is also very interesting in the case of RDS. So for those of you who are not that familiar with lung ultrasound, the principles are really simple. What we do see on the screen are the artifacts that will arise when the ultrasound beam reaches the intersection between the air and the fluids in the lung. These artifacts are dynamic. And since in our patient population, most of the lesions we will see, any disease is usually in contact with the surface, we will be able to see different patterns that arise and be able to make a diagnosis. What is recommended is to scan the whole lung, both lungs, except of course, if we're in a situation of pre-arrest or crashing infant, where we'll be asking specific questions. We want to scan the whole of the anterior, lateral, and posterior chest walls without disturbing the baby too much. And I've shown you how that would look like on preterm M, which is a mannequin. We have a hockey stick probe, but you can use any probe. If you have access to a high frequency linear, multilinear probe, that would definitely be the best because the lung is so superficial. And it doesn't take much time to scan the whole lung all the way down to the diaphragm in the anterior, lateral and posterior walls, doing either a vertical scan or a horizontal scan, or both. I prefer to do this because it does help me get a 3D vision in my mind. Having said that, I think it's important that we do not forget to scan the posterior areas, even though, as I will show you later, if we go through and use lung ultrasound scoring systems, we will not necessarily be scoring the posterior lung areas. The first thing to look for when we're doing a lung examination is to find the lung. It's fairly easy in the newborn, but you never know. When we're in the time in life where you might have some, congenital malformations. We can identify the intercostal space by finding the ribs, with or without acoustic shadowing. Sometimes it's only cartilage in these tiny babies. And in between, we will have this brighter hyperechoic line, which should normally be regular. And it is important to assess that really well, because what we'll be looking for is a back and forth movement of this pleural line, which shows that the parietal and visceral pleura are sliding together. It's not possible with the naked eye to distinguish both leaflets, but when we have this back and forth movement, we do know that everything is okay. Because in a normally aerated lung, the ultrasound beams cannot go further down than to the visceral pleura, because then they will be reflected back by the air, because ultrasound beams cannot go through air. And this back and forth movement will generate A lines, which are horizontal, static lines that are simply a reflection of the last thing the ultrasound beams reach, which is the visceral pleura. So just repetition of the pleural line, equidistant, and they show you there's air. And in a normal lung, this is what it would look like. This is in a 30-week-old preterm infant. This is linear probe, which is why the image is a bit squared. We've got one rib, another rib, and in between we have this well-defined line, which is the pleural line. And if you look well, you will see this back and forth movement with respiration, which is lung sliding and is normal. For me, this is the most important part of any lung ultrasound examination, to really see whether there is lung sliding or not, because absence lung sliding is never normal. But you can see this lung also by pattern recognition. It is relatively dark. There are no white lines. And what we can see are these A lines, these horizontal lines over here that show there's air. And this is what a transcostal horizontal view would look like. We don't see the ribs anymore, which allows us to see more of the lung area in a single view. It's easier to start up with the vertical scan because that's really what most publications look like, and it's easier to learn. But the inconvenience is that you have the rib shadowing, whilst it is a bit more complicated to get a good horizontal scan in the beginning at least, but the advantage is you see more of the lung. So this is a normal lung, and this is what we'll be using as reference, because what we're looking at today is an abnormal lung, a lung where there is an increased inflammation. In RDS, what we do have is surfactant deficiency, which will lead to alveolar collapse. We have an interstitial syndrome. And everything we see on the screen in lung ultrasound is really in relation to the ratio between the air and the fluid in the lung. So when the fluid component increases, we have the ultrasound beams can go a bit further in, and we have what we call B lines. So B because they come after A. And what's important to define a B line is that they always arise at the pleural line, and they are thick, they are white, so hyperechoic, they are vertical, and they go all the way down to the bottom of the screen, and they are dynamic. And if there are any A lines, they will erase them. And the more the fluid component, so the more the interstitial edema, the more the number of B lines. It's normal to have up to 2 B lines per intercostal space, but when we start getting 3 or more, then we're talking about interstitial syndrome, and we will have a gradual increase that will take us in severe cases all the way to this complete whiteout picture, which is the equivalent of the ground grass appearance that you can see on the chest X-ray. So a few B lines, multiple B lines, but we can usually distinguish them. And this is completely white lung, which would be typical for a neonatal RDS. And just quickly going through to the end, when we have areas of completely non-aerated lung, then we can see a real image because the ultrasound beams can go through. And what we do see is something that looks maybe like the liver or the spleen. And we can see, as we can appreciate here, white spots that we call bronchograms, or simply trapped air inside. So this introduction was to take you through to what I believe is really the summary of what lung ultrasound is all about. It's the different patterns, artifacts that we see on the screen that arise in relation to the ratio of air and fluid in the lungs. And we'll be concentrating on this area over here. A normal lung has around, let's say, 98% air, a little bit of fluid, which is where we see this picture. We saw a normal lung with lung sliding and some A lines. When we start to have an increase in the interstitial component, we will start getting the B lines, and they will increase gradually until we see this completely white lung appearance, which is typical for RDS. Are there any limitations to this technique? Yes, of course. Unfortunately, it's not magic. The main limitation of lung ultrasound is that for us to be able to see it, the lesions have to be in contact with the lung surface. Having said that, this is never a problem, almost never a problem in our clinical context. But it means that if we have a lung ultrasound picture that is discordant with the clinical picture or something doesn't make sense, we always have to do a complementary imaging technique, and that would usually be a chest X-ray. It's also not possible today for the newborn at least to assess for overdistension once we've aerated the lung. It's difficult to know whether it's just normally aerated or if it's over aerated. And as with any other technique, we need to be systematic when we're examining, which goes back to saying, even though I will show you the lung ultrasound scores, which have been simplified to only include the anterior and lateral chest walls, we still have to scan the posterior chest walls. So the subject today is RDS. And we're talking about babies who are transitioning. They're transitioning from a fluid-filled environment to an air-filled environment. And it would make sense to think that the baby in the beginning would have fluid in the lungs. In babies who transition well, even if the lungs are a bit fluid-filled, it's never a problem. However, we are faced with babies who present signs of respiratory distress as part of a complicated respiratory transition. And questions we might ask ourselves is, for example, is it RDS? Or is it maybe TTN? Maybe it's something else. But what should I do really? Should I keep the baby on CPAP? Should I admit the baby? Should I give surfactant? And of course, depending on the patient's age, the management will be also possibly a bit different. So Going back again to this normal ultrasound picture, lung sliding and a more darker aspect, then we'll move on to what we could see normally in the transitional period in the first hours of life. So we know that term babies or near-term babies who transition normally, let's say they have a very quick airway clearance of the fluid. Before the first breath, the lung looks consolidated because there's no air. And after the first breath, we will have this completely white out appearance of the lungs. And then very quickly within the first half hour, we'll start seeing the establishment of a clear pleural line with partial airway clearance. And most infants will achieve complete airway clearance within the first 4 hours. And what we do know also is that static compliance will gradually increase within the first 24 hours of life. And now we're coming to the real subject, 1, 2, 3. We have progressive airway clearance. The question is, can we use these patterns to see when things are not working out? How could we use this, for example, to see whether this baby needs admission to the NICU or maybe surfactants? And this is the first paper that came out using really this functional approach with showing that these different patterns can be very helpful to predict which babies will go on to have a more complicated respiratory course. So all the babies in profile type 1, the white babies, they all needed admission to the NICU in this population, none in group 3, and a few in the middle. And so what we do know is that we can early on, by just using pattern recognition, have an idea of which babies will have a more complicated course than others. And what about RDS? The first paper that came out to describe the findings came out in 2008. For me, this is where neonatal lung ultrasound really started, that and the other paper on TTN. And you can see these are the same patterns, except they're in the they're inversed. So black lung is a normal lung, like the one I showed you. We've got a black and white picture in the mixed types. We've got some A lines and some B lines. And this completely white picture is what it's typical for neonatal RDS. So neonatal RDS is homogeneous surfactant deficiency. So what we would expect to see is that both lungs would be the same. So we have a thickened pleural line. The lungs are completely white because of the multiple B lines that we're not able to count. We don't have any A lines, at least hardly any, because of the global alveolar collapse, which then gives this ultrasound picture. And this picture is specific to preterm infants. And I mean, we could also see the same picture on the screen in, for example, me, but you wouldn't be making the diagnosis of surfactant deficiency. In my case, you would want to look for other differential diagnoses. You would probably want to do an echo in my case. So this is why it's important to always know the clinical context, know which patient we're scanning and what the question we're asking is. So in neonatal RDS, because of surfactant deficiency, we will have these findings showing you here. This is in a preterm infant. You can see that the pleural line over here is very irregular. We have tiny consolidations that have been called microconsolidations or subpleural consolidations. There is lung sliding, and you can see that the lung is white because there are so many B lines. There might be one A line hidden somewhere, but this is a typical picture of severe RDS. And we can, depending on our machine settings on machines, we can have more or less severe pictures like this one here. So there are no spared areas, meaning that both lungs are the same. We don't have any regions where we have better aerated areas than others. And it makes sense. What I really like about lung ultrasound, that it reflects the underlying physiopathology, pathophysiology on the screen. And it makes sense also to include it in our clinical reasoning. Sometimes we might have even more severe cases like this one here. So I work in a European context where all babies with respiratory distress are put on CPAP in the delivery suite. So we have some kind of recruitment. We don't have any studies about, for example, severe RDS in contexts where babies are not put on CPAP or don't have any kind of lung recruitment. But we do have more severe cases when the collapse is more important, as you can see here. And we would really think that this baby could benefit from surfactants and from airway support. And I'd like to go back to this paper, which is the first one that came out about TTN, to show you the difference between both of them. Again, we're talking about pattern recognition, and we're talking about pattern recognition in the context of underlying physiopathology. RDS is global surfactant deficiency. And what we see on the screen is a reflection of that, whilst TTN is delayed fluid resorption. So we wouldn't expect to see the same thing on the screen. Delayed fluid resorption is delayed transitioning somehow. And the underlying lung edema is because of this delayed fluid resorption. So we would expect to have a gradient somewhere. We would expect to have some areas that are spared, meaning some areas that have been cleared, and other areas that are still quite fluid filled. And we would expect that the lower areas, the bases of the lung, would be more fluid filled than the apexes. And this is exactly what we see on the screen. We see that the lower lung areas, like here, have multiple B lines, like in this first intercostal space. And we can also see that other lung areas are normal or almost normal. We have lung sliding, and in the cleared airway spaces, we have A lines and lung sliding. And if we're lucky, we can sometimes see a very clear distinction in the two areas, what has been called the double lung point. And the double lung point is simply that we see two different patterns on the same screen with lung sliding in both. And you can see on one side of the screen, we have multiple B lines. In the other, we have a normal looking lung. We see the double lung point only in about 50% of the cases. But I'm showing you this to show you that it's actually quite easy to see the difference. You do need some training, but I mean, it's not as complicated as for echo, for example. In the most classical cases, you can very quickly look at the difference here between a completely white lung, no spared areas in any lung region, as compared to here, where you will have some areas that will be spared. And it has been shown to be something that we can learn very quickly, like in this paper from Katarossi's team, where we can see that even beginners can quite easily, let's say a high level of concordance, distinguish between these two patterns. So what now? How are we going to use this to base our decision on surfactant, if you want to give surfactant or not? Again, using lung ultrasound gives us a very good idea about the loss of aeration. And in severe RDS, we have severe loss of aeration. This is the problem. And we're going to be using this gradual approach to see how we can actually make a decision, basing it on the A lines and the B lines, and knowing that this is something that is increasing. I mean, it is proportional to the degree of interstitial syndrome. Multiple lung aeration scores are being used today. And it started out in adult medicine, where it's being used for ARDS to evaluate for extravascular lung water or to respond to treatment, for example, in ventilation associated pneumonia. But today we have adapted neonatal scores. And I would like to show you how we can use them to predict the need for surfactants in the preterm population. And we can also use them to predict which babies will go on to develop chronic lung disease. I did talk to you about the fact that using simple pattern recognition is something that can help us early on. This is in the delivery room, predict which baby will go on to need non-invasive ventilation and admission to the NICU. And the same population was the group 1 later went on to fail non-invasive ventilation and surfactants. The question was, could we use like a numerical score to predict the need for surfactant, knowing that in Europe, our European guidelines give us an FI2 threshold to help us administer surfactants. And this is where the study came in. The question was, could we actually see whether the simplified lung ultrasound score could correlate with oxygenation indexes, since we're basing our decision also on FI2 limits, and could we also see whether it could predict the need for surfactant as per the European guidelines? And the score is a really simple one. What we did was that we divided each lung into 3 areas: the upper anterior, the lower anterior, and the lateral area. So this is basically a simplified adult score. And using a score from 0 to 3, that will give a score to each region, and then we'll add up to get a global sum. So basically, a score of 0 is a score when you have less than 3 B lines per intercostal space. The score of 1 is when you have 3 or more B lines. So you've got a mix of A lines and B lines. A score of 2 is when you have severe interstitial syndrome, meaning that you hardly have any or you don't have any A lines at all. And consolidation is when you have a score of 3 is when you have a larger consolidation above 0.5 to 1 centimeter, because in severe RDS, you can have multiple micro consolidations like I showed you. So basically, this is an increasing, the score will increase with decreased aeration, meaning that the higher your score, the less your lung is aerated. And it was interesting to see that this lung ultrasound score correlated really well with the different oxygenation indexes that were used, and also correlated well, at least for the infants below 34 weeks, the subsequent need for surfactant works less for the babies above 34 weeks, and they are a challenging population. And I hope there will be a webinar on them sometime soon, because they really are difficult. And then going back to the study by Francesco Raimondi, who showed that using these patterns 1, 2, 3, the babies in group 1, they went on to fail non-invasive ventilation. And he shows these pictures. I think they're 30 or 31-week-old twins. And you can see their chest x-rays there. Both of them presented with respiratory distress. Both of them had the same clinical presentation and history. And for me, both chest x-rays don't look very good. So I'm not very good at chest x-rays. And I wouldn't really be able to tell which baby would need surfactant just based on that. But when I see the lung ultrasound scans, it does help me a lot. And I managed to see that baby in panel A needed surfactant, whilst baby in panel C did not. This is our challenge, isn't it? We know that we should give surfactant selectively, and we have to give it early on, ideally before 2 to 3 hours, if we want to reduce mortality on BPD in the tiniest babies. But we don't really have any easy bedside tools, do we, to estimate lung volumes? And our European recommendations, based on FI2 thresholds plus, clinical signs, are a bit, we'd like to get more help in order to make this decision. We know that FI2 levels often will increase after this time frame. And today in clinical practice, for me, the only tool we have available is lung ultrasound. So we did see that in this first study by Brad, the babies under 34 weeks with higher scores went on to need surfactants. And then the next step was to see, what about the smaller babies, the ones where we really want to have surfactant in early? Does it work for them? And this was a study by DeMartino that looked at babies below 28 and below 32 weeks of age, using the same criteria and the same score to see whether they would go on to meet the criteria for surfactant administration at some time point. And as you can see from this area on the curve, it works really well. In fact, it works even better for the tiniest babies, which makes sense because the really homogeneous group, either you do have severe RDS needing surfactant or you don't, as compared to, for example, the babies above 34 weeks. And the best cutoff for this global population was a lung ultrasound score above 8. And was even lower in the smallest babies. So this score correlates really well with the need for subsequent surfactant, even before an increase in FI2 values. So these babies were scanned before 1 hour of life whilst they were on CPAP. And then they went on to get their surfactant as per the European guidelines. The score also works well for surfactant retreatment, but I definitely would not recommend basing the decision to retreat using simply lung ultrasound, because a number of factors come in, and also because we don't have sufficient data. So this is a bit our story in the units, and it's still evolving. We started training our team in lung ultrasound around 2013. And within that year, we trained all our team, and everyone in our unit was sufficiently comfortable using it. We went on to use it as a first-line imaging technique. And by 2014, this was really the technique we were using. And for the next 2 years, we tried to do some, development research, try and see how we could use this lung ultrasound score in surfactant management. And by 2016, we were so convinced that there was an added value to this that we decided to change our clinical surfactant treatment protocol to what we call ESTER. Ester is echography-based surfactant replacement. So we're in France, and we use the word echography for ultrasound. So it's ultrasound-based surfactant therapy. And this is an example of our golden hour protocol for the babies who are born before 28 weeks. Basically, what we do is we stabilize the baby on CPAP, the babies who come in from the delivery suites or the outborn babies, and we will then get the lines in to avoid hypothermia, hypoglycemia, and within 45 minutes, we'll do the first lung ultrasound scan. And this is where the babies, either will go on to receive their surfactants, to use the insert technique, if they have a score above 8, or we just leave them alone if they have a score below 8. And going back again to the scoring system, a score of 0, a score of 1 is when we have multiple B lines, but we're still able to see A lines. Score of 2 is completely white lungs, so no A lines or hardly any A lines, and 3 is larger consolidations. And again, we'll scan the whole lung, but we will only give a score for the upper, lower, anterior, and the lateral areas. You'll ask me why. It doesn't make sense. Well, actually, we have looked into, not only us, several teams have looked into whether there's an added value in including the posterior feet. And there isn't really. The babies are just born, and there still isn't really a big difference when it comes to, dependent and non-dependent areas during the first hour of life. It is possible, and some authors do include the posterior areas, but it doesn't really give an additional value. It's just the scores, the upper value that changes. So again, a score of 0, you can see there's lung sliding. Here in this score, there are no B lines, possibly 1. A score of 1 is when you might have multiple B lines, but you can still count them somehow, and you've got areas where you have A lines. So you need to have a global overview, which is why it's important to just not look at one intercostal space, but really look at the whole region. A score of 2 is when we have no A lines, just B lines. Possibly we might have multiple small marker consolidations, and it's only when we have a larger consolidation where we will give a score of 3. And we have this probe, but you can again use the probe you have in your unit. If you have access to a high frequency linear microlinear probe, it's probably much easier. And to give you an example, this is in a baby who's really sick. But it's also to show you that it's possible to do a whole scan, even in tiny unstable babies, without them decompensating or without them being too bothered by the examination. So right anterior superior, going down all the way to the liver here, and we've got the right anterior inferior. The lung sliding is really quick because this baby is already on high frequency ventilation. Right lateral, so we're scanning all the lung. We go down to the diaphragm. You see there are multiple small consolidations over here, and the lung is globally with this white appearance. Then we'll scan the posterior area. Because we have this hockey stick probe, it's not always easy for us to have a vertical view without, turning the baby more around, which is why you will see a lateral scan, horizontal scan here. You can see there's a bit of effusion, with larger consolidations, but we will not be using this posterior area for scoring. But it does give us an idea of the fact that the lung is globally quite little. There's a loss of variation everywhere. Left anterior superior. And then you saw we got this organ that comes in the way, kind of bothers us sometimes, although it's useful to have a heart. The challenge is often to scan the left anterior inferior. You need to really change the angle of the probe to get a nice view of the lung. Left lateral. And then we'll be moving on posteriorly. And you can see that it doesn't really take that much time. The baby during all this time is completely stable. There are no desats. And again, we have additional information here. It shows that it's not sliding as well in the posterior areas. There are larger consolidation and a little bit of effusion. So a score here for me, if we would go back to the simple scoring system, I don't know if you've had time to evaluate and think of the score you would give, but I would give a score of 2 in each lung region. A 2 and not more, well, 2 because only B lines, so this white appearance, no A lines, but I didn't have any large consolidations, although I had multiple micro consolidations. The larger consolidation, especially posterior on the left side, I will not take into account in the scoring, but I will take it into account in my clinical reasoning. So for me, that would be 2 in all the lung regions I am scoring, which would be a total score of 12. And that would be way above the threshold of more than 8. And since we started implementing this in our unit, we wanted to see whether there was an added value, whether we were actually giving surfactant early on to the babies who needed it. And I was very interested to see whether we were not giving more surfactants. So basically what we did was we compared the standard periods where we were giving surfactant as per the European guidelines with the ESTA period, where we were giving surfactants either based on FI2 thresholds or a lung ultrasound score above 8, whichever came first. And then we checked for 12 months later on to see whether this effect was sustainable. And as you can see here on this chart, we were okay. I mean, we're not perfect before, but the arrow is where we moved on to ester, and you can see there's less variability. Most of the babies here were getting surfactant within the 3-hour time frame. And for the babies who needed surfactant, the proportion getting surfactant in the 3 hours of life went up, whilst the FI2 levels, maximum FI2 levels went down. And what we did see in the secondary outcomes was that we had a reduction in the duration of invasive ventilation and an increase in the number of ventilator-free days, possibly because we're giving surfactant earlier. And it didn't come at the expense of increasing surfactant use. We didn't increase it either. So having said that, it would be interesting to see in the long term. And these are the data we have for surfactant retreatment. You can see that depending on the studies, we have sensitivity that's somewhere between 80 and 90%, but the specificity, which is much lower. So again, I would not recommend basing surfactant retreatment only on this, also because of the surfactant half-life. However, when it comes to the first dose, I think lung ultrasound and lung ultrasound scoring is something that is extremely useful, as has also been demonstrated in the Spanish study, where the patients were randomized to either standard care, which is surfactant as per the European guidelines, or surfactant using the lung ultrasound score. And you can see from this camembert, so this is not a pie chart on the left, the control group, this is a camembert because we're in France. There's a tiny slice of camembert in the control group, around 8%, to actually get their surfactant within 3 hours of life. And all the others get surfactant later on when we follow the European recommendations. And in the ultrasound group, they all get surfactant within 3 hours of life. There are also a number of differences after surfactant administration. So this is a very interesting study because it shows the clear difference between both groups. And it really confirms the fact that it can be a useful tool. Of course, you might say, yes, but we're using the European guidelines as reference, but it is the truth today. We don't really know. We're not able to go invasively and check the surfactant pool or have other bedside techniques to evaluate. This seems today to be the only bedside tool we have that can allow us to screen babies and identify which babies have severe loss of aeration that will go on to need surfactant as per clinical criteria later on. And I do hope in the future that we may have other bedside tools like EET, and possibly we might need multimodal models. But this has also been confirmed in other studies, like this Italian study. Again, we have, especially in the tinier babies, less time to surfactant treatments when we use the lung ultrasound score versus when we're just using clinical criteria. And also what's interesting in this study is that the authors also use a simple measure that we can debate, But when they combine it with the SpO2-Fi2 ratio, they find that the accuracy increases even more. As you can see here, the area under the curve is at 0.93 when both are combined. And this is regardless of gestational age. And this seems to be very interesting. And I know they're working on a tool for that. So showing the different age groups, and then going again to this tool, which is this, predictive model of surfactant with both the score and the SF ratio when it comes to this multi-center prospective study. And just going back to this, or lung ultrasound scores, they have been validated in various settings against more invasive methods, and they do very well when you compare to, for example, transpulmonary dilution, ex vivo lung volume, and so forth. We actually have 3 meta-analyses already, with the last one that just came out, grouping the different studies. And also, you might see when you go into details, there's some slight variations in how the scoring is done. But in spite of that, and in spite of the fact that different authors might be using slightly different thresholds, lung ultrasound is highly predictive for the need for early surfactant replacement. And the risk of bias for these studies there were 7 studies in the end, is low. What's very interesting also is that there is possibly an answer to this question, because today we have 2 ways of, let's say, using lung ultrasound patterns to predict the need for surfactant. We can use a simpler scoring technique, which is the 1, 2, 3. Scoring system that was first shown by Catarossi and then used a lot by Francesco Raimondi. So going from more severe to less severe, and then breadth scoring system, which is the one we're using in my unit. And the question is one better than the other? Because one is simpler to use than the other, for sure. What this meta-analysis says is that both of them work just as well. There seems to be a similar performance of the 2 image classification systems. However, there is a lot less data on the simpler scoring, the ultrasound profiles. So I think it's worth working more on this to find out how we can best use it. Both of them, I would say, have advantages, and both of them have inconveniences. But in the end, both of them are doing exactly the same thing. They're helping us get an idea early on in the clinical course on which babies need surfactant early on, and which babies, if we had not intervened, would still go on to need surfactant as per the European recommendations. So in conclusion, I would say that lung ultrasound is the only available bedside tool we have today to evaluate aeration in our preterm infant population. And it is the only tool we have today that can predict the need for surfactant administration for severe RDS in preterm infants. We've seen the multiple scoring system, they're all validated, but I do think that we need to have some form of standardization. And I'm very happy to be able to collaborate with colleagues nationally, and many of them are here today, so that we can work together on this and try to make this accessible to everyone. And I'm also very curious to know about the impact we could have in other settings, like, for example, limited resource settings, because all the studies on surfactant use today have been done in infants on CPAP, where surfactant is readily available. But I do believe that this could be extremely useful also if the questions are a bit difficult. If you have to, for example, scan babies where CPAP is not as readily available, how would we change the scoring system or the patterns? What should we be looking at? And again, could it be useful to decide which baby could go on to have, maybe the few surfactant vials we have? Or maybe the question is different. Maybe the question is which babies need surfactant because access to, which babies, need CPAP for RDS when access to CPAP is limited. And I think there's a lot of work to be done there. And I know some teams are working on this, and I'd be very interested to learn from them. So I'd like to thank you all. And I'd like to thank the teams with whom I work every day at Paris-Saclay, and to invite you to come and visit us. I'd be happy to take your questions. I know there is one question in the chat, so I don't know, Mahmoud, if I should start up with that, or if you would like to, Virginie and Modena, if you would like us to do differently. So thank you very much.
Thanks a lot, Nadya, for this brilliant talk. It's always nice to hear everything from scratch, and it's quite, we have quite recent publication again with this meta-analysis. So I will start straight with the first question from Dr. Rebecca Gregorio. So thanks a lot, Dr. Yousef. What is your experience in lung ultrasound-guided surfactant treatment in long-term outcomes as BPD mortality based on your ESTA project? Thanks.
Thank you very much for that question. It is a very interesting one, and I would have loved to answer it. But I think that for now, it's complicated. It's really complicated. And Modena, she knows so much more on BPD than I do. I think that early surfactant administration is one thing in a spectrum of things that will influence progressions towards BPD. So we did not look specifically at the same patient population to see long-term outcomes. First of all, because there are so many other things that influence that. I think it would be very interesting in the larger studies to see, as has been shown, that using lung ultrasound scores, we're able to predict early on, starting the first days of life. There's a clear difference at 1 and 2 weeks, which babies will go on to have a trajectory towards BPD as at 36 weeks, and the ones who don't. But today, what can we do really to intervene? We're a bit limited in our options. We can try and change our ventilation strategies. We can try and improve nutrition, give caffeine, vitamin A for those of us who give that, and so forth. But I think it's still early days to be able to think that just by giving a surfactant earlier, we might because we're just small units in the end, with our patient populations, be able to see an outcome. I think we need much larger studies. I don't know what you think, Virginie or Modena.
Is that Modena?
Yeah.
Hello, everybody. Sorry for arriving late. I couldn't find the link in my email. Yes, I have to say that there's a multi-center European trial going on now trying to solve this question, that Dr. Gregorio is also involved in this, in which the use of surfactant guided by lung ultrasound in extremely preterm babies that are on non-invasive ventilation, trying to guess whether if this population could benefit as a reduced rate of BPD using this approach or not. As Nadia has correctly explained, we don't know the answer yet. We don't know whether if given surfactant earlier in this population could help us deal with this issue. We hope so. I hope we could get these results so that we will have more people using lung ultrasound, I think, but we don't know it yet. Thank you, Nadia, also for your talk. I really enjoyed it. There's another question from the chat, and saying that, could you please explain something about or your preferences about using lung ultrasound scores for predicting evolution of BPD?
Yes, I'm trying to pull out a slide I have. I'm again famously bad at using Zoom to share, so I'll try again. What we're using are actually the same scores. I mean, multiple, let's say, there are more. Can you see my screen first of all?
Yes.
Yeah. And I don't know why I cannot make it in presenter mode, but my apologies. So I think that what we can say is you can use the same scores to follow babies up and predict a progression towards BPD. And some authors will be using the very simple score, breadth score, which is exactly the same one as for surfactants, maybe including the posterior areas for an extended score. But it has been shown that both the more extended scores that may include even more lung regions, or a very simple score, show the same thing, meaning that there is a significant difference between the progression in lung ultrasound scores in both patient populations, and that can be seen starting a few days after birth, and is clearly visible at 1 and 2 weeks of life. As you can see, this is the at 1 week when you've got the two different scoring systems. So, and at 2 weeks, both of them have a very good predictive value. So I would say that it's the same principle, and basically what we're looking at is the same thing. It's loss of variation, how the lungs will clear up or not, really. And it's also very interesting, and I think it's with the more studies coming out, and possibly in the study that you talked about, Medina, we'll be able to see how gestational age comes into that, if we need to plot that in the beginning. So far, I don't believe we have any. We know that gestational age does play a role, but how we can use it in practice, I think, is still a bit tricky. Would you agree, Medina?
Yes, that's the first question I had here to ask you. Do you use a specific approach especially in those born before 28 weeks in terms of using different scores, or you always use the same threshold of 8 points?
For
think about this for surfactant administration, sorry.
Yes, we use the same today. Today we're using the same threshold for babies under 32 weeks. Above 32 weeks, we use lung ultrasound scores as an extra help, but we wouldn't base it solely. We don't use Ester in the above 32 weeks because we know it's a bit complicated. But it still gives us situations where we know that, we're still giving surfactant to babies who might have almost clear lungs, which doesn't happen very often. But let's say you have a 26-weeker, you have a lung ultrasound scan that's a fairly well aerated lungs, and you do know that probably this is something going on with the hemodynamics. We would still give surfactant. And that's today kind of limitations of the different tools we have available today. But we're still using, going back to your question, the same cutoff, although we were probably a bit more severe in the youngest babies. I think in the future, it would be interesting to see whether we should have a more tailored approach according to gestational age. So I think the question is open for debate.
Thank you. We have more questions in the chat, but there was someone here that raised his hand before, but I think we don't have it anymore.
Ahmad?
Yes, that was me. I thought the participants who are typing, they could go first. But anyway, thank you very much for letting me speak. Nadya, fantastic talk. It was amazing. I was waiting for this talk for a while, and what a pleasure. My question is, I'll try to give you the background of why I'm asking this question. So this concept and the emphasis that there should be a uniform appearance of, say, score 2, coalescing B lines in all acoustic windows in all the areas to conclude that this baby needs surfactant. This doesn't happen very often. I mean, you don't get 6 areas with very generalized similar appearance. So for example, you're saying score of 9 above 8, so 9 and above should be means we should be replacing surfactant. But if you score those numbers, 9 actually means you only have like 2 or 3 areas scoring 2. The rest would have 1s and maybe 1 odd with 0. So so the appearance of A lines very often is pretty acceptable when you have a bird's eye view of the lung and you think, okay, the surfactant is needed, although and including the lung score, which at 9 is actually doesn't really mean there'll be a uniform appearance of white lung everywhere. So so I guess my question here is, do you think 9 score really means uniform appearance here, and we should go ahead with a not very uniform appearance when we're giving surfactant?
Thank you, Ahmed. This is a very important question. I totally agree with you. I think that all preterm infants do have some degree of RDS. The question is really, is it severe enough for them to need surfactant replacement therapy? And what we've decided we're going to use as a criteria is, will they go on to meet the recommendations? I mean, the European recommendations. So what I mean by uniform is that you won't have some, for example, let's say that you're scanning a baby and you have a score of, I don't know, 9, for example, or 10. It's true that it wouldn't be the same thing if you have 2 large consolidations on lateral areas and well-aerated lungs. You know, you've got a score of 1 anteriorly. This lung is not a homogeneous lung. So although, of course, the score will be high, you need also to put it into context of what you're really seeing on the screen, where it's also important to look at the posterior areas. So going back to preterm infant who does not necessarily have complicated RDS, we don't suspect any infection. We don't know anything probably about whether it's a chorioamnitis or not, because that's also another factor that we're not taking into account and that one day would need to address as an issue. If you have a score of 9 or 10, you usually have somewhere between 1 and 2 in most lung areas. So you will have a few A lines a bit everywhere. When I talk about spared areas is where you have areas that are really, you know, relatively well aerated, that you don't have a homogeneous looking lung. And going back to Amadina's question, isn't it about gestational age? Shouldn't we be taking that into account? I think that the probability of, I mean, the younger you are, the higher the probability of having severe RDS. So, which is why in our setting where we're probably quite aggressive using surfactants, this would be enough to give surfactant. Possibly in other settings where the recommendations are different, I would probably guess in the US where I don't work, you might want to first recruit the lung more, maybe give more CPAP and wait. But you're completely right. A score of 9 would mean that you would score a 1 in 2 or 3 lung areas. But that's where the importance of having a global overview, of checking what is, and in any case, it's a bit difficult today to not give surfactants in preterm infants who have respiratory distress and have decreased aeration on lung ultrasound. And this question for me is even more important in the babies who are above 34 weeks because they often have a mixed picture and they're very difficult. But then we usually have more time. So I've talked a lot, Ahmed. I'm not really sure I answered your question.
No, you absolutely did. Yeah. So is my understanding correct that in situations like a LISA catheter providing surfactant to the right lung, so the left was still scoring high, the right wasn't, but we went ahead with the second dose of surfactant, which was actually the first dose for the left lung, and all those babies, when we are managing hypoxic respiratory failure, and they at some point need surfactant. So there are lots of interspersed A profile areas, and yet you would go ahead with surfactant. I
think today we do that. I think this is as far as our knowledge has come. And I think because this is the best tool we have, this is the best we can do as compared to doing this blindly, right? Or using just the chest x-ray. But I believe in the future, I hope in the future, when we maybe have complementary methods, we could get more answers to that. But I think this is the limit of how far we can go today.
Great, thank you very much. Cheers.
Okay, cheers.
It's 2 o'clock. I think we still have a bit of time for 1 or 2 more questions. We have one question by Dr. Ahmed Moharram. Thank you, Dr. Nadya. Do you have a standardized CPAP level in your unit before considering scoring by ultrasound?
Thank you, Ahmed. Yes, we do. We usually stay at CPAP level of 6. And I think in the future, it would be interesting to see, and I know my colleagues are working on this, to see whether we can titrate CPAP levels and see how the lung recruits before surfactant. But today, the short answer is we stay around the CPAP level of 6.
Thank you, Nadya. That's, oh, maybe Modena, you go.
We have another question from the chat by Rebecca Gregorio, and she wants to know whether if you have any protocol about performing new lung ultrasound after surfactant to differentiate the evolution, or maybe CPAP failure or need of second doses of surfactant, or if you use any score to initiate or wean mechanical ventilation immediately after birth.
Thank you, Rebecca, for the questions. We use the INSURE technique, so we usually extubate the babies right after we use sedation, and then when they wake up, we'll just extubate them, except if when in the beginning we can see that this looks more complicated. If you've got large consolidations or there's sepsis or something else is going on, the candidate would probably, and the baby would probably not be candidate for the INSURE technique. However, we're using more clinical criteria. If the baby is for some reason on mechanical ventilation because they didn't meet the criteria for INSURE, then we would use lung ultrasound before extubating to be sure that lung is well aerated. That would mean not any huge consolidations and so forth, but we don't have any specific protocol. It's more an additional point in a multimodal evaluation. So it's really the clinical context, the initial picture, and the baby's response when it comes to oxygenation and lung compliance and so forth. And we use lung ultrasound as an additional value. But we would not keep the baby on mechanical ventilation because the baby still has a score of 12, for example. We know it takes a long time before we can see any difference, although that is a bit baby dependent. So, yeah.
Okay. Thank you.
And the last question from Mohamed Tawfik, if there is any evidence about the choice of the type of respiratory support according to the diaphragmatic profile in lung ultrasound? That's a tricky one.
It is, isn't it? Good luck with that. We've got Modena, I can always ask her. But I would say that today, no, because lung ultrasound, diaphragmatic ultrasounds is being under evaluation to see how we can use it as an additional criteria to evaluate for the degree of respiratory distress. But today, to be able to see, stay on CPAP or use an IPPV, or maybe you need to intubate, I think that we don't have enough evidence. And also when it comes to using it for weaning off, it seems very promising, but I think they're still early days. Where we do know more is more, let's say, in post-cardiac surgery or in these kinds of patients. But for the preterm infant, I think we all believe that the diaphragm must be something important to look at, but I'm not really sure we know how. And so for now, is there any evidence? There's not enough evidence today to lead us. I think there are so many other factors coming in. So.
Thank you. Thanks a lot, Nadya. Thanks, Modena, for moderating this session with me. It was a great help. Mahmoud, I think you had a last question maybe for Nadya.
No, that's fine. We can leave it for another time. Yeah.
Okay.
Thank you so much.
Thanks a lot, Nadya. And thanks everyone for joining.
Thank you for joining us. Yeah.
Thank you.
Bye-bye.
Thank you, everyone.
Bye-bye.
Thank you very much.